Welcome everyone to this afternoon's session. We'll give people a few more minutes to sign on. For those of you just joining us, we're going to give a few more minutes to allow people to sign on. We'll start it shortly. Okay, well, I think we'll get started. Welcome everyone to today's webinar. On the screen, you'll see our disclosure statement for the CMEs that you'll be receiving. So take a few minutes to look at that. And here to receive your CME credit is the instructions for how you need to identify yourself. So you'll text the following code to the following phone number. You have 60 minutes prior, during, and 120 minutes after the end of the activity to text in your attendance. And by texting in your attendance, we will know to provide you with those CMEs. We'll also post these numbers in the chat so you can see them while we're having our presentation. So having said that, I'd like to introduce our speaker for today. Dr. Eleanor Turi is my colleague and a research associate at Penn Nursing and an associate fellow at the Leonard Davis Institute. Her work focuses on improving access to care for people who use drugs, advancing nurse workforce policy, and applying implementation science to promote equitable health outcomes. Eleanor is going to be speaking with us today about low barrier wound care for people who use drugs. So let me turn it over to you, Eleanor.
Hi, everyone. Thanks so much, Jordan and Tanya, for having me. I'm excited to talk to you all today about a topic that's very important to me, and I hope it is to you too, learning more about wound care for people who use drugs. I'll just say to start out, if you have any questions as we're going, is this the right view now?
Yes,
This
now
is
it
good.
is.
Okay.
Yep. Thanks.
As we're going, if you have any questions, feel free to put them in the chat or raise your hand, and Peggy will read them out to me at the end. But yeah, my name is Eleanor. I'm here today from Penn Nursing to talk about low barrier wound care for people who use drugs. So a little bit about me, my background. I am mostly a researcher and I study improving access to evidence-based nursing care among people who use drugs with a strong focus on wound care. And then I still practice clinically as a wound care nurse in a low barrier setting in Philadelphia. I volunteer there a few times a month, delivering wound care to people who use drugs in a large syringe exchange. And then I also still practice as an ICU nurse, which I've been for about 10 years. So I bring together my clinical and research experience to talk to you all today. about community-based care for individuals living with substance use disorders with a focus on the nursing workforce and wound care needs. And my research really comes from this belief that everyone, no matter their life circumstances, deserves high quality and accessible preventable health care. And this really comes into context with people who use drugs that have wounds that really deserve to get high quality care in a place that's accessible and comfortable for them. So today I'm going to talk a little bit broadly about people who use drugs and the wounds that they typically experience, where they get wound care and how to improve this care, and then discuss future work that needs to be done and have a just discussion with all of you about questions or comments or your experience working with this population. So I come from Philadelphia, where there is a high rate of contaminants or other adulterants in the drug supply, the illicit drug supply. This table on the left is from, we have a Division of Substance Use Prevention and Harm Reduction in our public health department, and they publish these reports every quarter of the year that test the drug supply and tell us what kind of adulterants are in the supply. This is the end of 2025, and as you can see, there's a ton of adulterants in the supply here. You rarely ever get drugs that are completely pure fentanyl or heroin. And one of the most common is right now is medetomidine, which is a sedative that makes people extremely sleepy and then causes these really horrible withdrawal symptoms. But one that I'm pretty focused on because of wounds that I'm sure a lot of you have heard about is xylazine. It's an animal tranquilizer that is known to cause necrotic wounds in the body, either from spilling the drug on skin or when people inject it. It can cause wounds all over the body due to vasoconstriction. And it's still present in about 28% of illicit drug supply uh, samples in Philadelphia. And then on the right is a map of Philadelphia. And as you can see, there is one county that has over 100 plus overdose deaths in 2024, and that's Kensington, where there's a really high concentration of poverty, substance use, homelessness. And then the table on the bottom is looking at the number of unsheltered individuals in Kensington compared to citywide. And you can see that in 2025, it was the lowest it's been, but it was still a quarter of unsheltered individuals in Philadelphia are concentrated in Kensington. And so that's really where my clinical work is focused and a lot of my research is as well, because there's a high concentration of this population there. They're exposed to xylazine, they're exposed to the elements, so they get wounds as a result. And there also concurrently is a lot of harm reduction organizations in this neighborhood that are providing really great care. And so that's really the community partners that I work with to study this wound care. So what kind of wounds do people who use drugs experience? There's wounds from xylazine exposure, which I'll show you in a minute some photos. And explain it a little bit more. There's skin and soft tissue infections, which includes abscesses, and then also just like cellulitis and dermatitis, which happens often because of like when you inject, there's not clean, they didn't clean the skin, or there's an infection that occurs at the site, and it can rapidly turn into like bacteremia or osteomyelitis. Wounds also occur because of social needs and exposure to the weather related to homelessness. As I said before, about a quarter of the population that I focus on is unsheltered homeless. And so in the winter, when there's snow on the ground, these people, their shoes get really wet and stay wet, and that can lead to wounds pretty easily. There's also exposure to frostbite. And in the cold as well, a lot of people start fires to try to stay warm. So there's burns that happen as well. Trauma occurs a lot, unfortunately, in this population. Infectious diseases, like mpox, other things like scabies, and then vascular wounds, I think are a little bit under-recognized in this population sometimes, but because of all the venous injection, especially in the legs, the veins often kind of collapse, and that often leads to venous wounds that are chronic. And when you couple the social needs with this population, they really have a hard time keeping them healed and doing compression. So I just have a couple photos of wounds, so fair warning, they're a little bit graphic, but I think it's important to show. So this is from an article of nurses that are really great here in Philly, and I would encourage you all to go read this article as well about xylazine-associated wounds. This is basically showing how they progress. A lot of the times patients will show up with number one pictured from an injection site or a spill on the skin, and it's just kind of these small eschar holes on their body. And then it pretty rapidly progresses to full skin necrosis. But with regular wound care, you can achieve 5 and 6, even in a low barrier setting with this person still living outside. And it's really horrific and scary, but with regular care, these patients can heal. Another example of a wound, this is an abscess that we see a lot in like the axilla or the femoral areas from injection sites. These heal pretty well with like salt water, warm compresses, and just watching and waiting. A lot of low barrier sites don't offer incision and drainage of abscesses. And so we do have to, if it's on a joint or the patient is having issues with mobility, we'll refer them to an emergency department or urgent care that can drain it for them. This is an example of trench foot or just over wet feet that happen a lot of the times in the winter, and it can lead to these fissures where there's really dry, cracked skin, and it's an issue of too much moisture and needing to clean the feet. And so there's a really high need for good foot care in this population as well, and there's not a ton of offering of that separate from wound care. And then the last one, this is a venous ulcer. These, you can see it just has these characteristics of like being very macerated and wet. And this happens a lot in this population. And the best treatment for venous ulcers is compression therapy, but it's really hard with a patient that's experiencing homelessness. So you kind of do the best that you can to heal the wounds and have them put on as much compression as they're able to tolerate. But it's difficult. So, I've kind of talked generally about the wounds that this population is experiencing, but to kind of take a step back, we can ask the question of where are they getting care? I've talked a lot about low barrier settings, but I want to talk for a minute about more traditional settings and why they aren't necessarily getting care there. So traditional healthcare settings like regular physician primary care offices or hospital settings have a lot of barriers for people who use drugs. One of them is limited pain and withdrawal management. So Peggy actually had a paper that came out in 2021 that looked at self-discharge rates in this population. And this specific population of patients with opioid use and skin and soft tissue infection had a rate of self-discharge of 29.1%. So 3 out of 10 patients were leaving the hospital before their treatment was finished. And this was compared to 15% with general OUD, but without skin and soft tissue infections, and about 1% in the general population. And they also found that one of the main reasons why people were leaving was because of acute pain issues that increases their likelihood of self-discharging from the hospital. So especially with wounds, with wounds comes a lot of pain. And so that really increases the risk of someone not completing their hospital stay. Another issue in traditional healthcare settings is stigma from healthcare providers. This is something that anybody can experience anywhere, really, but I think it's reported a lot more in healthcare settings, and there's a lot of great work that's happening in hospital settings to try to educate the nursing workforce more about the needs of this population, but it's still happening and still a reason why people leave the hospital. This is a qualitative paper that came out in 2020, and the patient just said they don't give you the care that you should normally receive in the context of like once they find out that you have an addiction. So these two things really create barriers for people who use drugs with wounds and in terms of getting acute care services. And then in terms of the general continuum of care, people who use drugs are also often denied from skilled nursing, residential rehab, shelters, and methadone treatment because of their wounds themselves, because the staffing in those settings don't have education on how to treat wounds. And so they'll just say, we can't treat you here, which is just kind of like ironic or counterintuitive in that like someone's trying to get treatment for their substance use disorder and they can't because of their wounds, and it just leads to this kind of like endless cycle. So that's really hard. And then with unsheltered homelessness, if people are discharged from the hospital with wounds that could require wound care, it really limits their ability to get home care services versus if they were in a shelter or somewhere more accessible to home care, they could get home care nursing that would help them take care of their wounds. So in the context of all of this, it's really limited to patients themselves, their family, their friends taking care of their wounds, or low barrier settings. So it just becomes this question of asking, how do we improve access to high quality wound care for people who use drugs? And one solution is these low barrier settings. And what I mean by that is a couple different things. First is this flexibility and high access in treatment, initial access. So the first time that they get care, it should be very low barrier. They should be able to get services immediately that day or the day after. And then flexibility and high access and engagement. So there is not a lot of appointment requirements. They don't have to show up at a certain day and time. They don't have to keep maintaining sobriety to be receiving treatment. Harm reduction oriented care is kind of this philosophical and relational approach to care, accepting patient goals for care, having non-judgmental attitudes, inclusive care, trauma-oriented or trauma-informed care. And then a lot of this isn't a requirement of low barrier settings, but most often they are in non-traditional settings like the street, mobile vans. They are in clinics, but usually in like neighborhoods that have a high concentration of this population. They can be in shelters as well. And then a new kind of innovation in this space is telehealth that can help bridge some of these gaps in care. But in general, with low barrier settings, there's a lot of high community knowledge. So the people that are providing wound care and the patients themselves, through like trial and error and just talking to each other, really know what works for their wounds. But there's not a lot of like evidence base in this setting in terms of the scope and skills in wound care. So there needs to be a lot more research in this setting of like, in this context of like low resource, no appointments, patient-oriented care, what works, and how do we scale up this care? This is a photo of an example of a low barrier setting where I deliver wound care. It's like behind a clinic in a tent. The patient would sit in this chair and I would sit here on the little stool and deliver wound care. And we have a decent amount of supplies. Like this is pretty good, but there's nothing too advanced here in terms of like active wound therapies like wound vacs or like fancy like cellulose dressings or anything. It's pretty basic wound care principles that a lot of people are applying. So one of the research questions that I asked in the last year or two was how can we scale up this wound care for people who use drugs in low barrier settings that we know kind of anecdotally works because patients trust it. It's really accessible to them. But sometimes there's really long lines for care. And then in the general context of this care, they still have really severe wounds. And how do we make sure that the wound care that's being delivered is the best possible wound care and appropriate for the severity of the wounds that the patients are experiencing? So this was a qualitative study with wound care providers, administrators, and recovery specialists in Philly, Camden, and New York. And I also, we looked basically at barriers to delivering low barrier wound care, and then we generated implementation strategies, which are basically like methods that can help improve the delivery of care. So I'll get into some of the results quickly. The outer setting barriers that affected the ability of providers to deliver low barrier wound care. One was stigma, which I've already talked about a bit, and how it can influence the delivery of care is that from like the city level or government level, there's a lot of stigma towards this population and this type of care, and that takes action in the form of policies and funding. Another outer setting factor is the social determinants of health in terms of like patients engaging in wound care. They rightfully so prioritize their like food needs, shelter needs ahead of getting wound care, and that often kind of that takes a lot of time for them to do and manage, and so it limits their ability to get wound care regularly. There's a lot of local policy and insurance coverage issues that affect wound care delivery in low barrier settings. And then the organizations that are delivering wound care are constantly applying for grants and dealing with Medicaid contracts if they even bother to do that. And so all of these barriers really come together to limit the ability of low barrier sites to deliver wound care. This is one quote from a provider that was talking about being in the same space, like delivering wound care in a food pantry. And she said, I think just being where people are eating is really important. It seems like sometimes that's a higher priority, but people will come to eat and they'll be like, oh, yeah, I haven't changed this bandage for how many days. So this is potentially a strategy for increasing engagement in wound care is making sure that you're delivering social services in the same space to really recognize that patients obviously need to meet those needs first before they address their wounds. In terms of intersetting barriers, so this is barriers at the organization level that affect access to care. A lot of these organizations don't have an electronic health record, which brings issues with tracking the wounds and progression. There's often just nurses there who, like registered nurses, who are not able to prescribe antibiotics. And that's really helpful in this context to be able to give someone oral antibiotics that day if you're seeing some cellulitis or other infectious issues and the patient doesn't want to go to the hospital. And then lack of clean space and costly supplies. Like I said before, you kind of do your best in this context in a tent or an outdoor space, and it's hard to maintain like a clean and sterile environment and be able to purchase expensive supplies when you're running low on grant money. This is a provider that was talking about a strategy that they use to get more people to engage in care. And so they said, we've noticed since putting up this tent, a lot more people are willing to roll up their pant leg. The nurses who did it before were doing a folding chair in the street, and you would get people who would walk by and kind of gawk at them, and they were pretty unsuccessful in getting people to actually sit down. So this strategy of having more private spaces is a mechanism for engaging more patients in care and really honoring the patient's dignity in giving them private care, especially when people have wounds on like their torso or pelvic area. It's important to give them privacy, which can be really hard in these like outdoor settings. But and then in terms of the innovation itself, so barriers to delivering good, high quality wound care. One of the barriers is there's a lack of standardization of evidence in this setting. So a lot of people are just following general wound care, like moist wound healing principles, but there's not good guidelines of how to deliver wound care in the street in these contexts of so many barriers. There's actually some disagreement in the field about the complexity of wound care that needs to be happening in this context. So a lot of people are just delivering really basic wound care of just let's just cover this wound and it doesn't really matter what we put on it. And that's the end of it and it's better than nothing. And then other people are saying like people are have their bone exposed in the street and it requires really complex, like high level of knowledge about wound care. And we need more trained wound care nurses in this space, even though it's hard to get them there. So there's some disagreement in the field about that. And then in terms of how people learn wound care, people are learning it from their friends and families, and then other people are going to actually like registered trainings and like really learning wound care from like a accredited source. So there's a spectrum of knowledge in the clinical area. This person just said, I have learned a lot by just getting really close to wounds and seeing the different parts of them. It's really a learn by doing thing. And then lastly, in terms of the individuals that are delivering wound care, there's a lack of specialized wound care providers that I just talked about. There's in all of Philadelphia, I know of 2 people that are actually certified in wound care that are delivering wound care. Not to say that the people that are doing it are not very experienced and good at what they do, but there's a lack of like certified trained providers out there. A lot of people are experiencing burnout. And then in terms of patients themselves, one of the issues of them engaging in care regularly is this fear of pain and withdrawal, which is very understandable. So this is someone that just talked about burnout. They were saying it's the hopelessness of both fighting against the system and fighting against these wounds that seem to be never ending. And so another part of this project was generating strategies to try to address a lot of these barriers. I'll just kind of list them now. I'm in the process of starting to try to test some of these, but there's a lot of work to be done to address all of these issues that we're seeing. But in the outer setting, one of the strategies was using mass media like social media to help address stigma, offering social services at low barrier wound care settings to engage more patients in care. So having food, clothing, transportation at the site is really important. Having a centralized department at the city level for wound care services. One of the things in Philadelphia that they do is the public health department distributes wound care kits, and that's really helpful in terms of sending patients home with supplies. And I think having a larger department would be really helpful in terms of resources and knowledge in the community. On the inner setting level, supply donations are really helpful. One thing that would help a lot of organizations more is billing for wound care. There's a new street medicine billing code in Pennsylvania and nationwide actually for Medicaid, but it's complicated with billing for wound care. I can get into that if anyone has any questions, but that's a potential strategy for scaling up care and having like a reliable source of income for these organizations. Changing the physical structure and layout, like I said before, with the tent, like making sure that there's private spaces for wound care. In terms of the innovation itself, partnering with academic institutions to develop the evidence base, using more community-based participatory research methods, and then promoting adaptability of the innovation. And what that means is just keeping low barrier wound care flexible and accessible to patients and making sure we don't create any more barriers to care. And then at the individual level, one strategy might be revising professional roles, and this might mean having a certified nurse oversee the care of a few different lay providers and just being there for consults so that you're able to extend the reach of wound care a little bit more and use their knowledge more effectively. Having a forum for hearing success stories of wounds to help address burnout among providers. And then doing asset building with the patient population. So really working with them of what works well for them, what are they doing that is helping to heal their wounds, and really thinking through how can we build on that to scale it up to other patients. Um, so one question that came out of that research that I talked about a bit is improving access to specialized wound care for people who use drugs. And one of the answers to that is woundostomy and continence nurses. It's this huge, skilled and knowledgeable workforce that's out there that really, really knows how to take care of wounds really well. Like that's their job. They do it every day in the hospital and home care, but their capacity and knowledge caring for people who use drugs kind of across the board is unknown. There's pockets of wound care nurses that really know it well, but across the board, it's unknown how much this is included in the education of wound care nurses and how much like stigma and attitudes are coming into play when we think about their delivery of care for people who use drugs. So another study that I worked on was looking at their capacity to deliver harm reduction wound care, which I'll define in a second, and then asking them about their interest in volunteering at harm reduction organizations, either remotely or in person. So just a little bit of background. So when someone is wound ostomy continence certified, they can end up just doing ostomy care or just continence care, but most 60% actually deliver wound care in their everyday jobs. And other providers report a lack of time, stigma, and limited guidelines that get in the way of caring for people who use drugs. And so one of my questions was, what gets in the way of wound care nurses delivering harm reduction wound care to people who use drugs? Is it these same issues, or is it something else that's going on? So this graphic shows what the definition of low barrier wound, or I'm sorry, harm reduction wound care is. This was generated out of the community here in Philadelphia. I think I have some citations in a couple of minutes of the people that really helped develop this. This was not me. But basically, there's 5 principles. First is like honoring the expertise of patients by respecting what they know works for their body. So if a patient says a treatment or product doesn't work for them, having a discussion with them about their preferences and goals is really important, to just respect their autonomy. Minimizing pain by acknowledging patient responses and removing the dressing slowly. Using saline is a really good trick to soak the dressing first. That helps release the dressing on its own, like from sticking to the body. Or a lot of the times I just let the patient remove the dressing themselves. Acknowledging wound odor in a respectful way. I think this is where you see the most reaction or stigma from people or like healthcare providers, is noting the smell. But just thinking about like, if this was me, how would I want people to be reacting? So offering spray and changing the trash and linens kind of throughout the wound care change can be helpful. Being aware of stigma that patients face in most healthcare settings, and just acknowledging that like them just sitting here and getting care with you is a big step in itself. And then if you feel comfortable talking with patients about injection and patient goals for healing, that's a really important step. I think doing it once trust is established first is a better move. I don't think you should talk necessarily about injection right away. But once trust is established, asking them about their injection practices and goals for healing, just because it can kind of scare a patient almost right away if you bring it up too quickly. You want to just establish their trust first. But those are the 5 concepts of harm reduction wound care that I was thinking about in this context of asking wound care nurses why they may or may not practice those principles. So this was a qualitative project and then a large survey of wound ostomy continence nurses. It started in the Northeast and then actually expanded nationwide. And we looked at knowledge, stigma, education, demographics, and then applied the theory of planned behavior that really thinks about the norms or the way that their environment influences them, their self-efficacy or confidence, and attitudes influence behavioral intention and behaviors. And in this context, the behavior was harm reduction wound care. So the results of the survey, we found that attitudes, self-efficacy, norms, and stigma all impacted their care for people who use drugs. So specifically their attitudes or their norms, so believing that patients would approve of their behavior, delivering harm reduction wound care. Those two things were predictive of them delivering harm reduction wound care or reporting that they would. Attitudes and confidence were predictors of being interested in volunteering in person at a harm reduction organization. And then stigma was significant for volunteering remotely at a harm reduction organization. So in general, these findings highlight the need for education for this workforce, coupled with systemic changes like staffing, um, support, and better. A lot of the wound care nurses kept reporting that it's really hard for them to work with bedside nursing, surgery, hospitalists. Like they have so many teams that they need to coordinate with this population. So having better communication at that level would also help improve care. Um, Another way to answer this question of how to improve access to specialized wound care is looking at telehealth. Um, it could help bridge access to specialty care in low barrier settings. So this was another model that I tested with funding from Penn Nursing Innovation Accelerator. So myself and another nursing researcher at Penn, Shoshi Aronowitz, built, developed, and scaled a model of telehealth for wound care for people who use drugs. So what I mean by that specifically is this is our little infographic of the model. But basically, it starts with a community provider out at a low barrier setting. It could be a phlebotomist, a medical assistant, a lay provider, whoever is there with the patient. And they identify this wound among the patient. Then they initiate a teleconsult with a wound care nurse, then deliver wound care together while the wound care nurse is there remotely. And they're using this conferencing platform to deliver this care. So it's bridging this gap and issue of there's not enough specialty knowledge of wound care in the community. And we have this great workforce of wound care nurses, but they're not physically there. So far, we've launched this telehealth model at 2 sites, on multiple sites in multiple days in Philadelphia. And we've had the busy clinicians that are there at the site are excited and interested in our model. But we haven't had a high patient demand. One of the issues, or it's not really an issue, it's kind of a good thing, is there's a change in the drug supply and xylazine no longer predominates the street opioid supply. People still have a lot of wounds, and a lot of people are dealing with chronic wounds that aren't healing, but there's not as high of a volume of patients. And then another issue that is going on is that there's staff questions or like flow issues. So having to stop in the middle of this really like intimate encounter with a patient and be like, okay, I'm going to call this wound care nurse that you don't know, can be a little bit awkward and weird. And so I think that's another issue that we're dealing with. It's just kind of that flow, and having more training for the providers of this model. So one of the strategies that we use to try to increase patient engagement in this model or needs or for getting wound care is we printed out this flyer and put it out in the lobby of one of the settings. And it's just trying to address some of the myths of wound care. So a lot of patients think that they should leave their wound out to dry, and we're telling them you need to keep it covered and moist. They should clean it with alcohol or hydrogen peroxide, but those products are too harsh. Feeling like their provider is going to be grossed out, but ensuring them that we've seen a lot and we won't be grossed out by it. And then thinking that wound care is going to hurt them and just really acknowledging that and saying like, it doesn't have to hurt, will not provide any wound care without your enthusiastic consent and participation. Okay, so bringing it all together, basically, I just kind of wanted to get across today that people who use drugs have a high burden of wounds that do require specialty care in some contexts. General wound care can get by for just kind of maintaining a wound or palliative care, but if we want wounds to heal, they do require a higher level of care. Um, but specialty care settings may not be the best fit for this population at this moment due to stigma and withdrawal pain management. Um, Low barrier settings are really promising, but there's a lot of barriers in the way of scaling them up and delivering more of this care. Bringing specialty wound care to low barrier settings is also promising, but there's barriers here as well, with stigma, attitudes, and then telehealth issues as well with flow. So in general, more evidence is needed to better deliver high quality care in these settings, and knowing what works and why would be very helpful in these resource scarce environments. So in terms of future work, this is one thing I'm trying to address is identify like evidence-based characteristics of low barrier wound care settings that are associated with better outcomes for patients. So trying to build that evidence base of what works and why in this context. Oh, I don't know why that did that, but we're going to still develop and test the telehealth model. Sorry, going back to the bigger study, in terms of the setting characteristics that we're looking at, it's looking at funding models, staffing, co-located services, and how those differences affect patient outcomes of engagement in medications for OUD, acute care services use, trust and satisfaction with care, safe injection practices, self-wound care knowledge, and HIV prevention access. So hopefully this study will help build a body of evidence that when someone is trying to open a new low barrier wound care site, they'll be able to point to this to say, okay, having a wound care nurse and food at my site is really important to having my patients trust me and use safe injection practices or whatever outcome they're interested in. So that's exciting. And then there's also a need for research in terms of HIV prevention in this population. People with wounds are high risk for both HIV and wounds, obviously, due to injection, drug use frequency, and overlapping vulnerabilities. And so there's a lot of overlap in terms of PrEP access, PEP access, HIV testing, and a lot of similar barriers. And so there's a lot to learn with how can we bridge the gap in those two care settings or care needs and kind of knock two birds out with one stone in the context of, because wound care is so like intimate and trusting that I think you can achieve a lot with patients in this context. All right, that was a lot, but I'm finished. One thing I did want to point out was, and I can put it in the chat too, is this harm reduction wound care tool that was developed by the city of Philadelphia. And it's this really great clinical resource. Let's see if I can share it. That you can click through and it'll show you, it teaches you a lot about xylazine, substance use wounds, and then if you get to this how-to guide, it kind of walks you through all of the different steps of wound care. So it's a tool that the city developed to help bridge the gap in specialty wound care needs in the community, and something that's really cool. And I just wanted to share that with this group because it might be helpful in your context. So yeah, I'll stop and answer any questions. Thank you so much for having me again.
Thank you, Eleanor. That was a terrific presentation. And we don't have any questions in the chat quite yet, but I do see that Jordan is validating that they are facing the same challenges and barriers to low barrier wound care in Southwest Ontario, Canada as well. So what you're finding is can be generalized to other settings as well. And there is an interest in seeing your having access to your slides, so maybe we can make sure that can happen, as well as maybe putting the link to that harm reduction wound care tool, make that available to our audience as well. While we're waiting for, thanks, Eleanor. While we're waiting for any questions, I would love to hear you talk a little bit about, I know you just recently underwent formal wound care training, and you brought some of this up in your discussion, but just how, most wound care nurses aren't thinking about the wounds that these patients suffer. And so as you went through that training, what kinds of, were you able to raise the consciousness, or what kinds of barriers, so to speak, were you encountering in your training around caring for patients who have who need wound care and also have a substance use disorder?
Yeah, I definitely did with both of my preceptors that I oriented with during my clinical time, and finding that and they had talked about too in my study that some nurses just avoid caring for this population totally. Like there'll be a team of 4 or 5 wound care nurses, and one is kind of designated as the person that likes this population, and they'll be the one that takes care of them, and everyone else takes all of the pressure injuries and diabetic foot ulcers and everything else that's in the hospital. So there's definitely a level of avoidance that's happening, at least that I've seen anecdotally. And then I think there's avoidance in avoiding the room altogether. And then when we're in the room, being really quick and just in and out and not wanting to interact too much with the patient. I've definitely seen that too. And just trying to show that it's hard in that context when it's like my preceptor and and I don't want to tell them what to do, but I think just trying to demonstrate that you can be empathetic and kind to this patient and take your time with them and asking them how their day is going and just treating them like a normal person. And I found that when I first started doing clinical work in low barrier settings, I was nervous too. And I think just with more exposure and learning that these patients are real people, there's nothing wrong, they're not scary. So I think just repeated exposure and learning that you can have a very normal, lovely interaction with this patient helps a lot, and in terms of addressing stigma. And so yeah, it's a hard issue because a lot of wound care nurses are later on in their careers, and there's kind of that education level of not wanting to do anything new. So it's a difficult issue, but in September, myself and Lydia Williams, who's one of the 2 wound care nurses in Philadelphia, are doing a webinar for the WOCN about harm reduction wound care, which will be exciting.
Terrific. Great. Thank you.
Thank you.
And people can also raise their hands if you don't want to put something in the chat, if you've got a question for Eleanor or want to contribute to our discussion. I think that the idea of stigma has been kind of pervasive throughout your presentation, Eleanor, and it has such an effect on the quality of wound care that these patients receive.
Mm-hmm.
I'm wondering, while we're waiting for some questions, if maybe you can talk just a little bit more about the current project that you're doing. You talked a little bit about this 5-year project, but we may have attendees here who are working with services like you're looking for in the Northeast, so they could maybe even direct you to places you could go. So if you could just talk a little bit more about what the study entails and what's required of the sites that you're working with.
Yeah, thanks. So it's a 5-year study, again, looking at how low barrier wound care characteristics are associated with patient outcomes. And so I'm going to 20 different low barrier sites across the Northeast. And sites can be included if they are low barrier. So if they don't have appointments for patients, they're walk up and they provide wound care. They don't have to, they can be like a brick and mortar setting, but if they're mobile or street-based, that's great too, like non-traditional settings. And I would do a survey with a provider of the site and then come in person to the site and interview 5 patients who patients are eligible if they have injected drugs in the last 6 months, and gotten wound care at this site in the last 6 months. So the cities I'm focusing on are Philly, Pittsburgh, Baltimore, Camden, New Jersey, New York City, and Boston, Massachusetts. So if anyone knows anyone in those areas, that would be amazing if you could connect me to them. I'm in the recruitment phase right now. I'm going to Baltimore in like 2 weeks to collect data from two sites, but need more. So yeah, it would be very helpful. But it's been a really cool experience going in person to these sites so far and seeing how they're delivering care and talking to the patients about what's gone well for them, what's needs to be improved, and hearing their stories. So I've really enjoyed it so far.
Great. Is there anything you've learned so far from your data collection?
Um, what have I learned so far? One of the sites had acupuncture at the site, and the patients all across the board like loved that. And obviously that's like a resource intensive offering. It was a pretty expansive like syringe exchange, but it's it was a cool co-located service that helped engage a lot of patients in care and honored their like dignity and autonomy and like gave them a different method of pain control too, and just kind of a way to relax and spend their day. So I thought that was a really cool co-located service, that every of the five patients that I talked to at that site, all five brought it up as like, this is the reason why I come here. And so that was cool. Um, yeah, and then in terms of what I was talking about before, that a lot of patients are denied from skilled nursing care and rehab and shelters. That is something that anecdotally we know, but it hasn't been documented. And so I'm trying to quantify that with my study and get numbers on that. So I've been asking patients if they've ever been denied or deterred from those settings. And it's about like one to two out of 10. So like
Wow.
maybe like 15% are saying that they've been denied from somewhere. So far, I've only had 10 patients, but it's definitely happening, and I'm excited to get some numbers behind that to help document it a little better.
Yeah, that's great. We know it's happening, but in terms of documenting the numbers, that's really important.
Yeah, yeah.
Great. Okay. Well, we're just about at the end of our time here. I'd like to thank Eleanor once again for this tremendous presentation. It was I learned a lot and gave us a lot to think about. Again, to receive your CMEs, double check the link and the phone number in the chat. And thanks again for attending. Bye, everybody.
Well, feel free to email me too if you have any questions or need anything. I'll share my slides.
Thanks, Eleanor. Bye-bye.
Bye.